Good morning, everybody, and thanks for tuning in. My name is Christine Eisma. As Cheryl had said, I am a nurse practitioner at Cancer Care Manitoba. I work in different disease sites, so my primary focus is in breast cancer, and then I also run the early survivorship breast clinic at the Victoria Hospital. I also work in the radiation oncology prostate clinic and the radiation oncology brain tumor clinic at Cancer Care. And today I was asked to talk about imaging modalities in cancer care. And, instead of me stating facts about what each scan does and what it doesn't do, which I will touch on, but the focus today will be on how each phase, how typically we break down the cancer care journey into several phases, and we talk about how imaging plays a role in each of those phases. There's a couple things that I would like you to, take home, and you'll see these themes throughout the presentation. And I hope that this kind of clears things up, and you can apply these and take these things into your own cancer care journeys. I have no disclosures. And I'd like to talk about imaging as a roadmap. Imaging will obviously play a crucial role in diagnosis. This then will dictate how we treat you. The treatment plan is then dictated by response. If you're responding, we'll continue on with disease monitoring. And imaging will play a role in each of those. Scans are not just pictures. They are tools that guide decisions from diagnosis to treatment and follow-up. And it helps us understand what's happening inside the body that we can't see otherwise. Diagnosis, treatment planning, response reevaluation, and disease monitoring guides safe patient care. Okay, so these are the toolboxes. Yep. X-ray, ultrasound, CT scan, MRI, PET scan, bone scan. Different scans give different types of information. No single scan can answer every single question, and that's why you see a lot of your providers ordering more than just one type of scan over your cancer care journey. So here's the toolbox in detail. So we've got X-ray, right? And this is pretty basic and common. These are quick snapshots of bones and lungs using low-dose radiation. This is used best for fractures in the bone, pneumonia, which is infections in the lungs, checking for lines and tubes and their placement. It's not great for assessing soft tissues and early tumors. We have ultrasound up next, and ultrasound uses sound waves to create real-time images. There is no radiation involved in this. It's best for breast lumps, thyroid, liver, kidneys, fluid, and guiding biopsies. I like to think about ultrasounds when I'm looking at lumps and bumps. It's not great for lungs, deep organs, and deep organs that are behind bone or gas. In CT scan, this is probably the most common thing that you see. These are essentially X-rays taken in slices, put together to create a 3D picture. This is best used for staging your cancers, lung, liver, and abdomen, pelvis, and in emergencies. It's not great for soft tissue and looking at fine detail of the organs. And this also uses radiation and contrast in most cases. Next, we've got MRI. This is magnetic. It's called magnetic resonance imaging. And these uses magnetic fields to create very detailed images. There's no radiation actually involved in the MRI. It's best for the brain, spine, joints, pelvis. We do breast MRIs very frequently for detailed characterizations and for liver characterization. It's not great for people with certain metal implants, if you've got claustrophobia, and it does take a little bit longer. Then we've got PET scan. PET scan shows a metabolic activity using radioactive tracers. This tells us how well these tissues are metabolizing and how much they're metabolizing. It's best for detecting active cancer. It helps stage some cancers, and it can clarify unclear findings that were found on other scans. It's not great for all cancer types, and it can give a lot of false positives with inflammatory reactions or infections. And then, of course, we've got the bone scan, and this highlights areas of increased bone turnover using a tracer. It's best for detecting bone metastases, especially for breast and prostate, and unexplained bone pain. It's not great for specificity, which means that just because there's a positive finding on the bone scan, this does not mean that you automatically have bone cancer or cancer in your bones. A lot of fractures and injuries show up on bone scans as well. and then, of course, like arthritis and things like that. And then we have, I didn't list it here, but a mammogram. But I thought it would be it's important to note. These are obviously for our breast cancer audiences, and what it does, it's low dose X-rays of the breast. We use it for screening, obviously, and detecting new breast abnormalities in survivorship. It's not great for dense breasts. If you have a dense breast, the guidelines do suggest more detailed modalities. Okay, so how do we pick what tools to order? Choosing the right scan is a very thoughtful process. We look at the cancer type and where it tends to spread, and which imaging modality shows what area is that area the best. So what we also like to think about is what specific question are we trying to answer by ordering this scan? So, are we, let's say, trying to check on the lungs, liver, or the lymph nodes? Do we need to know about structure or metabolic activity? Each scan has strengths and limitations. So we match the test to what we are trying to find out. We also try to balance how much radiation we need to expose you to get these scans. How quickly can we get this information, and whether contrast is required, and whether you as a patient can take the contrast. And obviously, we take in patient factors, like I said, kidney function, pacemakers, claustrophobia, metal implants. And another key point is we only order a scan if the results will change the management. Sometimes more imaging doesn't always mean a good thing. It doesn't always add clarity. It can actually add a lot of anxiety, it can add false alarms, and it can expose you to unnecessary amounts of radiation. So we try to choose the test that provides the most helpful information with the least burden to you as a patient. And finally, different scans answer different parts of the puzzle. Sometimes we need several types. So a CT for structure, and then a bone scan for bone turnover, and then a PET scan to see metabolic activity. So now I'd like to go into each phase of a typical cancer journey, and then tell you how imaging applies and what we would see in that stage. So in diagnosis, imaging obviously helps detect the cancer, and this is the first place that imaging shows up in the cancer care journey. This is often when someone has a new symptom, there's a new lump, there's an abnormal blood test, and that requires more intervention. Imaging helps us move from something might be going on to answering, let's understand exactly what this is. In the diagnostic phase, imaging helps us see things that we can't see or feel from the outside. And for example, a mammogram or an ultrasound for a breast lump, a CT scan for chest or abdominal symptoms, an MRI for something deep in the abdomen pelvis, often for liver, and then a PET scan if we're trying to understand whether something is metabolically active. Each tool, again, you'll hear me harping on this throughout the presentation, but each tool will give us different information. Some show structure, some show activity, and together they help us form the first picture of what actually might be happening. This stage is truly about clarity and precision. Is this cancer? Is this something else? And how confident can we be in those decisions? And this, I think, is pretty self-explanatory. Imaging confirms size and location. The details matter because this influences the next phases of your journey. It can influence the type of biopsy, the surgical approach, or the treatment plan moving forward. And I'll give you a couple examples. If we order a breast ultrasound, this can tell us whether the lump is solid or if it was a cyst. There's a CT scan can show whether a lung mass is touching the chest wall. An MRI can help differentiate between scar tissue or a true mass. And then, of course, imaging guides biopsies. This allows us to more accurately perform a biopsy. This provides less invasive biopsies, and it's obviously much safer. Most biopsies today are image guided, meaning we use imaging in real time to help us guide to where we want to go inside the body to obtain the appropriate biopsies. And then, of course, imaging helps us rule things out. Not every abnormality is cancerous, and imaging helps avoid unnecessary procedures or worry. I think what the take home for this phase really is that I always remind my patients that imaging is not just about a search for cancer. It's a search for answers. The more we know upfront, the more confident and personalized a treatment plan can be. Patients at this stage are often anxious because imaging often represents a vast world of the unknown. And the next phase of your cancer journey is staging. Once a cancer is diagnosed, the next crucial step is staging. Staging means understanding how much cancer is present and whether it has spread to other parts of the body. It gives us the full roadmap before we need to decide on the treatment plan. So staging doesn't show us just where the cancer is, and it also shows us where it isn't. This matters because cancer behaves differently depending on its stage. A tumor that is fully located locally behaves very differently than a cancer that has spread to other parts of the body. And then imaging allows us for a better and bigger picture, not just the original tumor. In many cases, staging helps us decide whether a patient is eligible for surgery, radiation, systemic treatments like chemo, hormonal therapy, or immunotherapy, or a combination of these options. So, for example, a breast cancer that appears localized on mammogram may still need an ultrasound or an MRI to check if lymph nodes will or have been involved. A lung cancer may require a CT or a PET to determine whether surgery is the right option or whether chemotherapy can be considered. And then prostate cancer with bone pain, a bone scan may require also a PSMA PET to see if this has also spread elsewhere. Different stages mean different treatment plans, and any imaging that we order is a foundation of that decision-making process. And this is just another slide to show that not every cancer uses the same imaging pathways. I think I've said that enough. For example, I'll give you a couple more examples. In breast cancer, we'll do a mammogram ultrasound up front, and then we will certainly provide you with a CT scan, chest, abdomen, pelvis, plus a bone scan to determine if there's spread. For something like, let's say, lymphoma, a PET scan or a CT is often preferred. It all depends on the type you have, but generally, most scans or most cancers will undergo some form of staging. Staging imaging must be accurate before the treatment begins. We never want to understage cancer. I always tell patients that staging is about giving us certainty before we start the treatment. It's how we make sure that every decision we make is based on the most accurate, up-to-date information. Next up, we have the treatment plan. Once we know the stage, the next step is the cancer journey. In the cancer journey is treatment planning. This is where imaging becomes incredibly important because it helps design a plan that is safe and personalized to you. And the only thing I really want to talk about in the treatment plan phase is how imaging can apply to radiation. Radiation planning, imaging is the blueprint, truly. For radiation, imaging is absolutely essential. Before anyone receives radiation, they undergo a special, what we call, you'll hear a CT sim. The CT simulation is what radiation oncologists use to map their treatment plan. It's not a diagnostic scan. It is much lower dose than a regular CT scan, but it gives us a clear image and allows the physicists and the radiation oncologists to determine what they're going to target, how they're going to target, and how much of it they're going to target. I wanted to put this up here because it can be a little bit confusing. The purpose of the CT sim the purpose of a diagnostic test is to find, measure, and check the cancer. The CT sim purpose is not diagnostic. It only uses radiation. It only is used in the radiation treatment planning phase. Now we have monitoring. So you've undergone treatment, and now you're coming back to your follow-up appointment, and you're often faced with scans to review with your oncologist. Once treatment begins, imaging plays a key role in monitoring how well it's working. Once we compare scans done before the treatment, so in the diagnostic phase, to the scans during the treatment and after to look for patterns and trends over time. For example, chemotherapy may show changes fairly quickly, while others may take longer, sometimes months, before even before we see a meaningful shift in imaging. Not every change on imaging means the treatment isn't working. So you'll hear the report, the oncologist will go through it with you. There's a lot of big words and a lot of different things that sound scary, but not every change that you see and that they report on doesn't mean that the treatment plan is not currently working. So you'll hear also sometimes it's very common to hear a flare effect. This is most common in things like immunotherapy, where inflammation temporarily makes things look bigger and worse before they actually start to improve. So we always do it. We tend to do a series of scans to make sure that we've got the trending reports. So here we are in survivorship. So we're done your treatment, you've gone through the scans, your oncologist has cleared you, and now we're in this phase called survivorship. The big takeaway here is not everyone needs routine scans. It's not easy to hear this as a cancer care patient or a family member of a cancer care patient. It's normal to want reassurance, but more scans don't always necessarily mean better care. They can cause anxiety, false alarms, and unnecessary radiation. After treatment finishes, one of the biggest questions people have is, how do we make sure that my cancer isn't back? And this is where survivorship and follow up imaging comes in. It's a very individualized process. Surveillance depends on the cancer type. Not every cancer behaves the same way. So some cancers are most likely to return in the first few years. Some are monitored best with physical exams and symptoms versus scans. Others have very specific imaging schedules depending on national guidelines. Imaging and survivorship is not a one size fits all. Not everyone needs routine scans. For many cancers, studies show that routine scans actually in people that don't have symptoms do not have improved survival, and we do not actually end up catching recurrences in a meaningful timeline. And sometimes we actually are inducing a lot more harm with false alarms and unnecessary biopsies. This doesn't also mean we're doing less as providers. It means that we're doing what's proven to help you. Your team follows Canadian based guidelines so that you receive care that is both safe and effective. Follow up is, again, I like to harp on this, is based on symptoms and guidelines. We don't ignore anything. If someone has new symptoms that are persistent, we absolutely will investigate, including imaging if this is appropriate. The goal is to avoid unnecessary radiation and cost and anxiety from overscanning. It's completely normal to want reassurance. And follow up is a combination of science, guidelines, and your lived experience. And we make sure those decisions are made together with your healthcare team. Here are my take home messages. Every scan has a purpose. Imaging is chosen intentionally and not routinely. Different scans show different things. Not one single test will answer everything. In survivorship, most scans or more scans don't necessarily mean more safety. Follow up is based on symptoms and guidelines. And I think that's all. I think I want to leave on this note is that imaging is only one part of your cancer care story. It's not the whole story. Your voice and your symptoms matter, and we're here for you throughout the journey.
Okay, great. So I think I'm going to come back on line here with Christine so that we can not only field questions together, because I think that the neat thing about what you're saying, Christine, is you're addressing so many of the medical aspects of what people need to know about imaging, but you're also talking about the experience and what you notice patients wanting and what would provide, I think what you're saying, maybe some short-term reassurance. However, it's important to note, and Christine sees the medical side of things, and I see the psychological side of things. There are also ripple effects to weigh in, because I think we've both worked with folks, with families where maybe there was a false positive, and then the ripple effects of that. And so great start for some talk here, folks. And I think we have a good amount of time for us to field questions. So please keep them coming in. But the first question that I see coming up is, when I was diagnosed with breast cancer, I did not have any scans other than my initial mammogram. Why do some cancer patients have certain scans and others, like myself, have none?
Great question, and I can understand why you're asking this question. So, obviously, I don't, without knowing the exact details of what was found on the mammogram, if there was no further CT scans that were ordered for you, in this case, it probably meant that the mammogram provided enough detail for us to determine that this was actually a low risk breast cancer, and that there was a low risk of spread throughout the entire throughout the rest of your body. And if you were asymptomatic, that in combination with a very reassuring, or not a reassuring, but a mammogram that shows that this was low risk, so oftentimes a CT scan elsewhere is not indicated. Um, and again, I like to tell patients too that uh, that decision for not having a CT scan can always be discussed with your care provider. I'm assuming would have been a surgical oncologist to determine and coming to that decision together and having that discussion in a meaningful way in the office when they've decided not to do it. Ask questions and see if there's a way that your anxiety can be reassured, or if there's any, if you've brought up concerns, sometimes the physician might say, okay, that seems reasonable. I think we can send for scans just in case. It's a very individualized uh, a process, obviously.
So before we move on to the next question, Christine, what I think you're getting at is that my guess from hearing many stories and talk from other medical professionals is that maybe, I don't know, 40, 50 years ago, it used to be a very different way of delivering care where, I don't know, maybe it was more everybody got this. And now I think we're moving towards, how did you frame it, Christine? More individualized or a cure consideration of one's circumstances.
Yes, yeah,
Does that make
yeah, that
sense?
does, yeah,
Yeah.
yeah.
Okay. And so, next question, are images available on the Nuna app or just in person?
Images are not yet available on the Nuna app. We're not providing, I don't believe we're providing imaging reports on Nuna yet. I know we're doing lab work, but not imaging reports just yet. So, yes, it is just in person or over the phone when you speak to your provider.
Okay. What are some examples of symptoms which would warrant a scan?
This is a very individualized question. It all depends on the type of cancer you have. So let's go from one end to another. If you had a very early diagnosis, low risk breast cancer, non-metastatic, low risk features, no lymph nodes involved, um, and then you had your treatment plan and you came back, the next 6 months and said, I feel something on my other breast. That would certainly warrant a scan, 100%. If you were a prostate cancer patient and said, Christine, I've got this really bad hip pain. I don't know what to make of it. I've tried everything. I went to physio. I've been working out. I've been doing the exercises, but it is persistent and getting worse. Scan immediately. Um, so it all depends on what you're coming in with and what type of cancer you have. It's a very personal question, very individualized question.
How about this one, Christine? How much radiation is in a CT scan?
Uh, so I think the statistic is one CT scan radiation exposure is equal to 1 to 2 years, the normal amount of radiation any human would get by being on Earth for 1 to 2 years. It is 100, or I think it's 100 times more than an X-ray in terms of radiation exposure, but still quite minuscule when we're talking about risk versus benefit. So we're ordering a scan because we're obviously trying to investigate something, and the risk of not knowing this is much greater than exposing you to, or not exposing you to the radiation of a CT scan. I hope that makes sense.
Yeah,
Yeah.
yeah.
Okay.
Okay, so this one, I think this is one is touching on themes that you've already covered, but why don't I get routine CT scans to check for recurrence?
Yeah, so again, very personal. And if you're not getting routine scans, this is based on guidelines. And I harp on breast a lot because that's my focus, but in breast cancer, um, After the treatment phases are done, for most breast cancers, we would just order annual mammograms on the contralateral breast, so on the opposite breast that was affected, if you had had, let's say, a mastectomy. And we don't order scans because it provides a lot of anxiety, if especially if you're asymptomatic. And big studies, large studies, have shown that we're not actually benefiting you by ordering scans if you're asymptomatic in that setting. And so, yeah, it's a very personal experience as well.
Mm, absolutely. And another interesting question here, is contrast dye safe?
Yes, it's safe for most people. We will do our safety checks to make sure that there is no, that you've not had any previous allergies to contrast dye and that your kidney function is good. But for most folks, contrast dye is safe.
Okay, great. And another one, oh, that I'm not sure if we've covered. Okay, I think that may or may not. Oh, here it is. What is the risk of the infusion used with CT for scan?
The risk is quite minimal. Really, it's a bit of an uncomfortable feeling when they give you the dye, and it gives us a better detailed image of what's going on in the lung. So, in terms of risk, very minimal. Some folks do have allergic reactions to it, but these are rare and often well controlled. And we that does not preclude you from getting any more infused CTs. We'll just pre-medicate you appropriately to avoid the reaction.
Okay. I'm just so impressed, Christine, by how you're fielding all of these questions.
Oh,
They're very, they're very technical.
they can
Um,
be, yeah.
yeah, absolutely. And so behind the scenes, everybody, I know we have a terrific team who's going through the chat. And while we have this valuable resource here in Christine, I just want to make sure that people have that time to put in a last minute question. I see my team looking through the list here, and I think that yeah, we've got everything that
Great,
people have wanted to know in the moment. So
great.
again, Christine, thank you so much for all the work that you do and for really making this so understandable. I mean, it can, as a lay person who is not medically trained, it can seem overwhelming, even though I work in the system. But I really think you've done a great job at really um, making it concise and valuable information for
Great.
folks.
Thanks. Thanks for having me.
Oh, thank you. Thank
Hey,
you,
thanks, Cheryl.
Christine.